The purpose of this video is to cover the general concepts of elbow stability, and not only for an FRCS perspective, and it's not certainly anything to do with like the tips and tricks for any exams. It's more so just to kind of try to get down into the basic principles of elbow stability. And I believe that if you understand what gives you the stability, you then know how to deal with that later on when you do encounter cases where you've had trauma, dislocations, subluxations, and any other associated ligamentous injuries around the place. So my general concept of anything, and I've been changing this a lot during my training and realizing that this is the case, where I was probably hedging my bets at times about the information that I knew and the knowledge, and looking for the high yield topic is a very common thing that you hear throughout life in general, but also medical school. And what do I need to learn to get the best marks? And actually, I think when it's come down to it, I've now realized that you actually need to know all of it if that's what you're going to work with your practice. So I think the first thing you need to do is understand the anatomy. And then the idea of these slides or videos is to condense it and distill it down to the stuff that, even though you're looking at it across the board, you do still get that proper understanding, hopefully, at the end of it. So the elbow joint stability, the primary and secondary stabilizers of it, the bony anatomy that is relevant and specific to stability, the distribution of forces with regards to how the joint works and that kind of touch on biomechanics. And then we'll touch a little bit on the patterns of injury and then the acute versus subacute and chronic. And there's another two videos that will follow with this that try to make it a little bit easier to understand as we go along. The bony anatomy, and not to be teaching people basics, but it's just to remember what we're looking at here. So you have your three specific joints which make up your overall elbow joint. So you've got your ulnohumeral joint, your radiocapitellar joint, and your proximal radioulnar joint, or your PRUJ, or your PRUJ as people might call it. The biggest part that I want you to think about with regards to the ulnohumeral joint, though, is the coronoid process. The first thing to remember on this is that it is intra-articular. It stops the ulna moving posteriorly relative to the humerus, and it engages a bit more as you come into flexion because it has that hook. When you get that nice true lateral, or if you're going through your sagittal CT slices, you'll get that nice view of that hook around the front that lodges into the coronoid fossa at the front. Now, to get even more nitty on it, the coronoid process itself has a very important medial facet. And coming around the corner from that, you then have the sublime tubercle. This is about 18 millimeters distal to the actual tip of the coronoid. And this is very important because, one, it's below this that the ulnar nerve will run, but also more importantly, the MUCL, or the medial collateral ligament, attaches here. So therefore, by definition, if your medial facet is off, your MCL by definition is compromised. Now, whether you do or don't do something with it is a different conversation. We'll talk about that later. The other stuff to remember is that the capsule attaches 6 to 8 millimeters distal to the coronoid tip. So you'll hear, and I've even seen it on ortho bullets, where it actually says on some of the coronoid topics that it's an avulsion of the tip, and that's not possible because nothing attaches to the tip. There is nothing that attaches there, so therefore it can't be avulsed. You can have a coronoid process avulsion, but if that's happened, you're looking at a type 3 where you've got this big chunky basal coronoid process. The brachialis muscle attaches just distal and medial or ulnar to it as well. But bear in mind that this is not something that will be involved in avulsion of the tip. So if you have an avulsion, you've got a big massive chunk and you're realistically going to have to be working with that from a surgical perspective. If you move on to the radial head, then again, this is something that I think that you end up seeing a lot of it in trauma, in fracture clinic. It's a very common piece of bony anatomy that ends up being injured. But actually, if I asked you to sit down and describe to me, one, the overall anatomy of it, and also the biomechanics of it, it's something that I would have struggled with quite a lot before. It's only covered by cartilage for about 240 degrees. Some books or sources will tell you that it's actually 270 degrees. I would suggest that you look at it from 270 because it gives you a smaller area for that to be the safe zone on the lateral side. And then we look at the concept of that safe area being where we would actually run our screws if we're going for subchondral cannulated screws for a radial head fixation. This is really important because you're looking for that safe zone to make sure that you're not then encroaching on the PRUJ that we touched on already. And that's something that you need to just be aware of, that you're not creating problems later on down the line. You've got that beautiful X-ray, but then they've got a supination, pronation block because your screw head is catching them. It may not be a true block, but it will irritate that area. PRUJ then ends up becoming damaged. The joint types as well. I think this is something that, again, with my understanding of the knee and as I was coming through learning about that, that was another part that I found really important, that there are two different joints within this joint. So the ulnohumeral joint is a true hinge joint. It has a central fulcrum point through the capitellum to the medial epicondyle. But also, more importantly, the radiocapitellar joint is a pivot joint. So it's not so simple. It pivots, but it also flexes. It's asymmetrical in shape, and it has significant ligamentous support from your annular ligament, your radiocapitellar ligament, and also your lateral ulnar collateral ligament, or your lucal. So for the purpose of the rest of the talk, I'm going to use the term lucal, and then also the effect that it has on the PRUJ with regards to its rotation as we're moving along. So the bony anatomy is really important. If your elbow is completely extended at 0 degrees, 40% of the weight is actually distributed through the ulnohumeral joint, with 60% going through the radiocapitellar. So if you look at the bony anatomy and the surface area, the radiocapitellar joint is vastly smaller, but it takes 50% more weight than the ulnohumeral joint. So this is something that you have to respect. During fracture clinics and the Mason classifications and the radial heads and all that, it seems to be kind of poo-pooed a little bit and just brushed under the carpet as an injury. But the radiocapitellar joint is something that needs a huge amount of respect, so that you are looking for the problems. And it's back to the whole known unknowns versus the unknown unknowns. So if you don't even know to look for it, then how are you expecting anybody to pick up on it? You have to have a stable radial or lateral joint column for the sake of the conversation, to allow a suitable range of movement and also to allow axial loading. If it isn't stable, you have to ask yourself why. Is it because of the injury, or is it because the intervention that you have instigated with your treatment isn't allowing for it to be stable? And then you need to look at, am I doing something precarious with regards to the rehab? Am I slowing them down? Am I allowing them to get a bit more movement, or what am I doing? So you need to be very careful regarding your radial side of your elbow joint. A lot of this stuff now is taken directly from Ortho Bullets, because in fairness, I do quite enjoy their layout of it and it's very useful. But what I do want you to do as well is, when you're looking through the likes of Ortho Bullets, is you need to go to the right hand side of the screen and look through their recommended reading for their papers that they have. And there's a number of them that I'll show you through the series of videos. The anterior band of the medial collateral ligament is the main stabilizer for distraction and valgus forces with the elbow in extension. You then also have your lateral complex of ligaments. So you can call it a lateral collateral ligament, but as we've touched on, you've got your AL, your RCL, and your lucal as well, all make up your LCL in total. And then separate to that, then you've got your primary stabilization effect by the bone between the coronoid, the trochlea, and the olecranon. And remember, the trochlea has a front and back, so you've got both fossae. You've got the coronoid fossa and the olecranon fossa, the trochlea and the spool in between, and then the coronoid and the olecranon at the front and the back, respectively. This is a very nice paper from 2001, and what they talk about in this particular paper is the effect of active movement of the muscles with regards to the stabilizing effect around the elbow through its range of movement, and also the effect of pronation of the forearm, tightening that lateral collateral ligamentous complex, and how it brings that into play. And they talk about how the effect of supinating tightens up this element here of the annular ligament, but also of the effect of the radiocapitellar ligament being involved with the radial head and rotating, and it tightens it. And it actually talks about how a pronated forearm is almost, if not as good as a supinated one without the injury. So pronation is better. So pronation with an intact ligament is obviously the best there is. Supination with an intact ligament comes after that. But in between the two of them, pronation with a transected ligament is actually better than supination with an intact ligament, oddly enough. So with the local side of it, not obviously the whole ligament, but it's just something to bear in mind, that your position of the elbow, and they talk about the Fonzie rule of thumb with regards to either being at the top, running across to pronation, or running back to full supination as it is, and that position for your stability. And they talk about pointing the thumb to the intact ligament. So either the local LCL or turning it and then pointing it towards the MCL. This is really important to look at with regards to the actual effect here. So you've got your annular ligament, you've also then got the joint capsule itself running here and at the back, and then you've got your radial collateral ligament which runs across here. But your local itself will actually run from here, will actually slide at the front here, down across here, and they haven't drawn this out for us for the local itself, and that's something that you need to be aware of, and we'll touch base on that in a few other pictures coming up, as you can see here. So your RCL runs directly in the axis of the center point of the capitellum down the axis of the radial neck. The local itself then comes across like a hypotenuse of that triangle, and then the annular ligament runs directly straight up here, and then your anterior lateral collateral ligament here runs over the top and then amalgamates with the annular ligament over the top of the radial neck, or radial head rather. So you can imagine that if we transect the RCL, you still have a huge amount of support from all of these. However, if you take this out, you've lost that hypotenuse connection, and it's the same in my mind as if you look at a table and you've only got the cross of it and then the two legs here. But ideally, if you had ones that were going up like this as well, connecting it, or across here, it would give you that extra stability to move it. So this prevents that extra distraction and is also vital in rotation, because the PRUJ is attached, and this then by definition links across to the PRUJ and links across to the radial head as well, because of the capsule around the PRUJ. This is just a separate view of the same thing with a bit more of a focus on the local, and I think that this is probably one of the most under-respected ligaments in the elbow as a whole, and it's one of the very high-yield topics that I would suggest that if you learn nothing else about elbows and stability, the LUCL or the local is going to be, as we just touched on at the start, is going to be your high-yield topic. Read around it. You could cover most of the literature that are the seminal papers in about 15-20 minutes, and the amount of knowledge and understanding you'll get from just Sean O'Driscoll's work on the local is huge. O'Driscoll's Fortress was something that, again, initially when you're trying to just do it from a memory base, this is a little bit difficult to remember. But if you just think about it, at the top of your triangle, you have got your bony structures. We've already talked about how important the coronoid is, and the coronoid is part of the ulnar-humeral articulation. So the outside border of your fortress has to be your ulnar-humeral bone. So bone at the top, ulnar-humeral above radiocapitellar. If you come over to this side here, you've got your medial side. So then soft tissue ligamentous outside of your tendon. So then this is medial, your CFO is also medial or ulnar. And then the last remaining ones are your CEO on the radial or the lateral side, which gives you your local. So these two link together on the lateral side, these two link together on the medial side, and then it's bone at the top. And the ulnar-humeral joint is more important than the radiocapitellar, so then that's on the outside. The concept of this outer triangle then is actually your joint capsule as well. And the concept then is that if any of this is breached, you have to look at the stability aspect of it. So if both of these are intact and your internal triangle is intact at that fortress, generally speaking, you are safe. If the outside is all intact, but your internal triangle is breached, you still have a stable joint, but the chances are of you having a normal LUCL, given the fact of having a radiocapitellar injury, is quite low because of the nature of the injury mechanisms as well. So the fortress just gives you an idea of how you can look at it, and it's a bit of an aid memoir as well. But for the purpose of your career, not just your FRCS preparation, I do want you to consider that a lot of these patients are probably being under-referred to elbow specialists, or at least that we could actually learn them as generalists as we're coming through in our training, how to manage these and where we should be bringing them back to fracture clinic a little bit earlier, bringing them to the appropriate fracture clinic for the upper limb team, or also considering an operative fixation at an earlier point as well, which would not be the worst idea. We move on to Sean O'Driscoll's paper. He first described it in 1991, but again, this paper in 1999 gives a very nice rundown of the posterolateral rotational instability, or PLRI concept. And his work on this is huge, and this is definitely where I'm focusing a lot of my interest in at the moment. If you look at the abstract from that particular paper, you look at here, so the treatment is surgical by repair or reconstruction of the lateral collateral ligament complex, specifically the ulnar part, so the local, deficiencies of the coronoid and or radial head must be assessed. So he talks about, again, back to his fortress, and you have to look at those and consider what you're dealing with. But because of the fact that the outer fortress has been breached by the lucal being damaged, you then need to consider, is the coronoid affected and is the radial head affected? And that means that two pillars of the outer fortress are affected and one on the inside. So therefore, you don't have elbow stability at this point. Another one that came out in 2008 from Charalambous as well talks about the PLRI instability of the elbow, and he touches a lot on the work of O'Driscoll's efforts and also his information and the basis of what he's worked on. But this also then specifically talks about the PLRI and gives a lot of insight into how we need to be looking at these as well. Don't forget about the medial side though, and I know the big part of the high yield stuff is going to be the PLRI, but with regards to this surgical side of things, and the team that I'm working with at the moment have told me 95% of the ligamentous interventions around the elbow that they perform are on the lateral side or the radial side. 5% of it will be the MCL, and similar to the knee, the MCL is very forgiving. In this case, it's because we've got two bands, and they do break it down into two ligaments, and then the anterior ligament theoretically has two bands. I wouldn't get too stuck on this element of it. I would just learn the fact that you've got an anterior band and a posterior band. Anterior band is tight in extension, and like we said, that's the main stabilizer and the primary stabilizer to valgus and distraction stresses. You've then got your posterior band, which is tighter in flexion. I've said here to remember this because this is really important when it comes to the fact that if you've got somebody who has a flexion deficiency, you will have to release the posterior band of the MCL. Now, to get down to there, though, you need to transpose or at least elevate the ulnar nerve out of the cubital tunnel to get to it. And that brings in a different conversation with regards to what you do with the nerve after that. There is a third ligament in this complex. It's the transverse ligament. It has absolutely, well, it virtually has no effect on stability, so I wouldn't get too upset about this. It's interesting to look at it. It's nice to know that it's there, but ultimately, it's not as important. So just to recap on these two, the anterior ligament or the anterior band of the MCL is tight in extension. It has two bands with an anterior and posterior, but they work the exact same. So anterior tight in extension, posterior tight in flexion. And then if you look at the subsection, the anterior and posterior are exactly the same when you take the anterior and oblique ligament of the two of these together as well. Here you can see the bundle, and it makes sense that if you were to extend this elbow, this would actually get longer and longer as it would come across here, so that's therefore tight in extension. As you flex, because of this, this then becomes tighter, and because of the way it fans out in a triangular shape, this is something then that would get tighter in flexion. This transverse bundle doesn't really do particularly much in the stability concept of any of this. So now what? You know the anatomy, you've taken your history, you've seen your x-ray, and you've reduced the joint in the ED, or your colleagues have done it. So what are you going to do now? So the concept of these then, again, on a very good paper like we've touched on already, is looking at the stabilization effect of pronation and supination and also the range of movement. So with regards to this, there's a very nice schematic that you can follow for these, for the lateral, and remember this is only lateral, for the lateral elbow instability. If it's an acute simple dislocation and you can achieve reduction with closed reduction and you've proven that it's stable, and by stable I mean that you've done your special tests, you can then say that you can put them in a dynamic brace for 6 weeks. If they are unstable at extension, pronate them, see if they're stable, and if they are, therefore they are stable at pronation at 0 degrees. If they're unstable at that point, bring them up to 30 degrees. And if they're then stable at 30 degrees with supination, Bob's your uncle. If they're not, then you pronate them, check if they're stable at 30 degrees of flexion with pronation. If they're stable, then you can still go ahead and treat them as a stable patient. But if they remain unstable at less than this, then you can see that if they're stable above it, but they're unstable below it, then you need to consider a ligamentous repair. So from 0 to 30 is a really important one. Because you come into flexion past 30 degrees, a lot of the other secondary stabilizers will become bigger players in the actual assessment. So with regards to this, you're looking at them being unstable at less than 30 degrees of extension. And then the problem then is you're looking at them being fully extended. And if they're unstable at this point, you then need to think they're at a high risk of posterolateral rotatory instability, and you then need to go down the road of ligamentous repair. If you look at the top right-hand side here, though, then we look at the chronic side. And from what I've been taught here is that anything greater than 3 to 4 weeks is probably chronic and may have contracted and may not be suitable from a biological perspective. And then you need to consider possibly augmenting their native lucal with an allograft or an autograft. If they're symptomatic, and this is again depending on if you can do their pivot shift test in clinic, that is quite uncomfortable for them and there's a lot of apprehension with it. The drawer test with the elbow in supination, but in 90 degrees of flexion with the radial head being translated front to back, again with the patient supine, that is a very good indication for it. But the very easy one then is just to get them to do the push seated position and see can they lift themselves out of the chair. And if they can't do that, they have got posterolateral rotatory instability and therefore they need to be considered for surgical intervention. Then obviously you talk about the risks and benefits and then their expected return to function. With regards to the concept of stages, you need to look at how far are you along on your timing, but also the staging of their instability and whether you're doing a ligamentous repair or you're doing a ligamentous reconstruction. If you were talking about this for your exam, you are already streets ahead, and I would be very surprised if you managed to get to this point with regards to a discussion around this in the short period that you have for your vivas. As I've said already, the medial side will only make up about 5% of your operative cases. Now, if you don't touch them, you don't operate on them, the literature would suggest that 42% will return to pre-injury performance at about 6 months. Now, that may not be acceptable to high-performance athletes, to professional athletes, and also, for instance, if they get to 6 months and they're not back to normal, you're then considering doing surgery for them and you're losing another 6 months. So be careful of the fact that a lot of stuff that's done in the professional sporting world does not correlate directly with what should or should not be done in the amateur sporting world or in the soft tissue ligamentous instability world for people who are not athletes but are manual workers. There's lots of rehabilitation. The compliance will dictate who you take on for this surgery, and then you have to look at the outcomes. So if you operate on patients, around 90% will return to their pre-injury performance with the newer techniques. If you look through ortho bullets, they talk about the old figure of 8. They're now talking about humeral docking, which ultimately is that they make a tunnel on the humeral side that is linked by 2 converging tunnels, and then you put an interference anchor into it, and then you also then put an interference anchor into the ulnar side as well. So the technology has come along. The literature is still catching up on that just to check what works and what doesn't. But then some people are doing an endobutton type construct. There is a suggestion that this should be kept for your revision stages, but again it depends on what works in your hands. And again, this is something that is very niche, very upper echelon type of knowledge, and if it's not something that you're looking to do in the long run, I wouldn't worry yourself too much about it. The take home from the MCL side of it, of the elbow, is not just under half, but under half of people return to pre-injury performance at 6 months. If you operate on them, 90% will get back to that point, but that does not suggest that it's a good reason to go ahead with it, because like I said already, to get to your MCL reconstruction, you need to handle the ulnar nerve, and ulnar nerve neuritis and fibrosis and scarring and compression and ulnar nerve injury is not a risk to be scoffed at. So you really have to be sure that you are undertaking this in the correct fashion and in the correct patient. So the summary of this then would be, firstly, and you could probably apply this to anything really, you need to know the anatomy first properly. You need to know the biomechanics of the articulating surfaces. You need to know the stabilizers, and you also need to know what you can sacrifice. You can comfortably sacrifice the posterior band of your MCL and not affect the stability of the elbow. You also need to know what must be repaired and reconstructed, and consider the fortress and the outer and inner walls of that fortress as well, and what's desirable versus what has to be absolutely categorically fixed or repaired at the time. You can then decide when you must operate and when you can wait, and also then in knowing what the expected outcomes are for the natural history of the injury, the recovery, and the potential interventions. And I mean, you could apply any of this to any pathology, any trauma, any topic across orthopedics. And I think if you take this approach to your learning, you'll come out of it a lot happier at the far end, where you can bring it back to base principles, regardless of the question you're asked in the exam, and regardless of the case that's put in front of you on your next trauma list, and just consider, what are the critical parts, what am I restoring, what am I trying to work on, and what are the expected outcomes from this. How am I going to change my rehab? How am I going to limit the patient and what they can do? And if you understand the biomechanics and the stabilizers and the bony anatomy in the first place, you know what you're putting back into place, and you know what you have to put back in place and what you can sacrifice.